Hi everyone, I'm Dr. Ranjit Singh Dhaliwal. I'm working as an anterior segment consultant at Eye Infirmary, Nabha in Punjab. I'll be speaking on special intraocular implants. The development of cataract surgery with the implantation of intraocular lens implants has been one of the major achievements of modern medicine. The intraocular lenses provide a near perfect optical rehabilitation with minimal magnification and excellent optical properties. The advent of small incision cataract surgery, made possible by phacoemulsification, manual SICS, and foldable intraocular lens implants, is another major milestone in the development of cataract surgery. It is important for the ophthalmologists to have a thorough knowledge of the materials used, basic design, and optical features of the various intraocular lens implants currently in use. I'll be showing you the most common and popular design of the anterior chamber IOLs. This is an anterior chamber multiflex IOL, neither much used nor very popular even now because of its safety concerns. Bullous keratopathy is the majormost complication that can occur. This IOL is an anterior chamber phakic IOL. It is again neither much used nor very popular because of its safety concerns like all other anterior chamber implants. Bullous keratopathy is again one of the majormost complications that could occur. Iris claw IOL was designed initially by Dr. John Wurst and it was popularized in India by Dr. Daljit Singh. Iris fixated IOLs have haptics that fix the IOL to the mid-peripheral iris like the claws of a lobster, thus giving them the name iris claw lenses. Interestingly, the plain simple iris claw IOLs graduated to being phakic IOLs as well as toric IOLs. Typical phakic IOLs are the artisan and verisi IOLs. There is also a toric artisan available in 5 mm model which corrects astigmatism up to 7 diopters. Amongst the posterior chamber implants, the PMMA single piece IOL is the IOL which is most used when implant is to be placed in the capsular bag after an ECCE or manual small incision cataract surgery. The optic size varies from 5 mm to 6 mm in 0.5 mm steps. The overall length of this can be 12.5 to 13 mm. Posterior chamber IOLs come in another design also. PMMA 3-piece IOL is mostly used these days when an implant is to be placed in the sulcus due to various reasons. A slight variation in the design of the edge of the optic of a single piece PMMA posterior chamber IOL makes it a 360 square edge IOL. This small advancement has reduced the opacification rate of the posterior capsule by a significant amount. Amongst the foldable posterior chamber IOLs, this design is the most common implant to be used, and the variations in the design of the haptics may make these as C-flex or S-flex IOLs. Next come the multifocal IOLs, which could be rigid or foldable. The rigid PMMA and the foldable multifocal lens implants consist of an optic having 3 zones. The central zone is 1.5 mm wide and is adapted for distance vision. The second zone from the center out is the zone with maximum addition and has a power that is 4.5 diopters greater than the power in the central zone. This zone is adapted for near vision. The second zone has a diameter of 2.5 mm and the third zone has an addition of 1 diopter over the central zone power and extends up to the periphery of the optic of the lens. This zone is adapted for intermediate distance vision. The PMMA haptics are shaped in the form of a modified C for better centration and lens stability. The combined effect of the three zones, along with the normal functioning of the pupil, results in an increase in the amplitude of functional vision. Limited zones result in lesser number of transitions, thus reducing the chance of scattering, which results in better contrast sensitivity and low glare. The multifocals can tolerate decentration up to 5 millimeters. Now, as the surgeons went on reducing the incision size, the IOLs also had to keep pace. So this micro IOL came into being. This IOL implant can be implanted through a sub 1.5 millimeter incision. It has a cross-sectional thickness of less than 1.5 mm when rolled. The lens design is such that it gives controlled and smooth unfolding. A better memory ensures that the bag remains distended, and a good posterior capsular contact helps prevent PCO. And as the 1 millimeter barrier was broken, the rollable IOL came. This IOL is suitable for implantation in the phaconet technique through a 0.9 mm surgical wound. This is the most modern advancement in small incision cataract surgery, and complete phacosurgery through the two side ports is possible in this technique. This IOL has a thickness of 100 microns and is available in pars ranging from plus 30 to minus 30 diopters. These ultra thin lenses are made up of hydrophilic material. The front surface of the lens is a curve that resembles a radius, and the back surface has a series of steps with concentric rings. The back surface can be concave, convex or plano. Before use, the IOL is removed from its container and placed in a bowl of BSS to make it pliable. It is then taken into the surgeon's hand between the index and the thumb. The lens is then rolled in a rubbing motion and held with a forceps for insertion through the side port incision. Once inside the bag, the IOL gradually opens up as it warms up to the body temperature. And then we have so many specialized posterior chamber IOLs. The accommodative IOL is the first one that I will show you. An accommodative IOL is a two-element lens. Each element is shaped like a saucer and is designed to fit snugly in the bag. In this, the dioptric carrier is implanted first and the second portion, bag maintainer, is implanted later. This holds the bag open and prevents shrinkage due to fibrosis of the capsular bag around the optic portion. This is an implant that may be of use in certain cases of central corneal opacity. A large optic IOL is machined in such a way as to remove all unwanted portions of the optic other than a peripheral quadrant. This is positioned under surgically created iridectomy where clear corneal tissue is available in the optical path. This is an interesting implant going by the name Panoptic IOL. In this implant, the central opening is 1.5 millimeters and gives pinhole vision when the iris constricts to around 3.5 millimeters. There are two foci or multiple focal points as seen in multifocal lenses. Thus, the quality of vision due to improved contrast is better. It works on the principle of small aperture resulting in an increased depth of field. During dim light conditions and when the pupil dilates beyond 3.5 millimeters, light enters the eye through the periphery of the lens. It can correct surgically induced astigmatism up to 1.5 diopters based on the same pinhole principle. The lens is designed for in the bag placement for better centration. This is called a Prism IOL. This IOL can be used in cases where there is stable macular disease and loss of central vision. The lens incorporates a prism which shifts the image from the diseased part to an extrafoveal position, thus enabling the patient to see better. An easily identifiable prism base ensures proper insertion and location within the eye. This may be a useful tool in place of aggressive retinal translocation procedures. A scleral fixation IOL is ideally suited for secondary implantation where no capsular support is present. Loops are provided with fenestration for easy suturing to the sclera. The design of these IOLs ensures proper placement and centration. A cosmetic IOL with an opaque black circular part in the middle where the most of the haptics have their visual access is, I don't know where or who might be using this. I have no idea. It was seen by me once upon a time. An Iridia IOL is an aid for patients with damaged or no iris. It can be manufactured to the patient's specifications. This type of an Iridia ring is a useful tool to correct pupillary defects due to damaged or torn iris. This too can be manufactured to patients' requirements. The capsular tension ring, or the CTR as it is popularly known, was initially introduced to reinforce the capsular bag in eyes with zonular dehiscence and to prevent phimosis of the capsular excess in eyes at risk for postoperative capsular shrinkage. Since then, other designs and applications have been developed and described. Modified shield CTRs can be used in eyes with iris coloboma or an iridia. A CTR with loops is used for scleral fixation. It is still not known if the presence of the CTR helps avoid or limit capsular opacification. Capsular tension rings are made of polymethyl methacrylate and were introduced in 1993. Standard rings have expanded ends that have positioning holes to facilitate manipulations during surgery. The modifications which were introduced by Morsher include models with integrated iris shields of 60 and 90 degrees, models of capsular bending edge rings designed to reduce secondary cataract and prevent capsular fibrosis, and models with one or two adjunctive loops for transscleral fixation of the bag without distorting the capsular excess. The Sioni ring has a fixation hook for severe or progressive cases of zonular deficiency. The hook arises from the loop to run centrally, then curves anteriorly into a parallel plane where it runs peripherally to end up with an eyelet for manipulation and suture placement. This design allows additional suture fixation to the eye wall without distorting the capsular excess opening. The hook is positioned opposite to the meridian of decentration to be pulled peripherally using a transscleral fixation suture, counteracting capsular bag centration and tilt. In the end, I am extremely thankful to all my friends and the manufacturers around the world who have provided me the photographs appearing in this presentation. Thank you once again, and thank you all for your patient listening.